Welcome to our second talk on alterations in cardiovascular physiology. And in this talk, we'll be looking at heart failure. So just to remind ourselves that the cardiovascular system is made up of two pump systems, the systemic circulation driven by the left heart and the pulmonary circulation driven by the right heart. In this talk, we'll be looking at heart failure. And you can just pause and remind yourself of the various cardiovascular parameters we'll be talking about in relation to the left or systemic circulation and the right or pulmonary circulation. Let's start with acute left ventricular failure. So typically acute left ventricular failure is caused by a reduction in contractility of the left ventricle, often due to cardiac ischemia. So the left ventricular ejection fraction is reduced, and this leads to a reduction in stroke volume and ultimately a reduction in cardiac output, usually with a reflex tachycardia. Because the ventricle can no longer deal with its venous return, there is an increase in left ventricular end-diastolic pressure and ultimately end-diastolic volume, although there may not be an increase in end-diastolic volume initially. If we look on the upstream side to this, so looking at what is happening to the left atrial venous return, this backs up and ultimately backs up to the pulmonary vasculature, leading to an increase in pulmonary arterial and pulmonary capillary wedge pressure. This then has an impact on the right ventricle. Although early on the right ventricle may not be affected, as the condition develops, this backup of pressure into the lungs will ultimately lead to an increase in right ventricular end-diastolic volume and pressure, as the right heart is not really designed to deal with high pressures and will not be able to empty effectively against a high pressure in the pulmonary vasculature. This ultimately leads to a backup into the CVP and IVCs, leading to plethora and an elevated CVP. But again, early on in left ventricular failure, both CVP and IVC may be normal. On the downside, so on the afterload side of the left ventricle, the decreased cardiac output leads to an increase in systemic vascular resistance, which then leads to an increase in mean arterial pressure, both an increase in systolic and diastolic pressures. This affects blood flow regionally. So we try to preserve our heart, lung, brain circulation at the expense of non-essential systems such as the muscles, skin, and the splanchnic circulation. Okay, let's have a look at chronic cardiac failure. Chronic cardiac failure is essentially biventricular failure. There's poor contractility both in the left and right ventricles. In the left ventricle, the decrease in left ventricular ejection fraction leads to a decrease in stroke volume and a decrease in cardiac output. As before, this also leads to a buildup of blood in the left atrium and an increase in left ventricular end-diastolic pressure and volume. On the afterload side of the left ventricle, this decreased cardiac output leads to an increase in systemic vascular resistance. And according to the contractility of the ventricle, this may be accompanied by either an increase or a decrease in mean arterial pressure. This cardiac output leads to a global decrease in blood flow to all organ systems, although there is some attempt to preserve the heart, lung, brain circulation. On the venous side of the systemic circulation, remember that the right ventricle is also failing and therefore can't deal with its preload. This causes a backup of blood into the venous circulation, leading to an increase in capillary hydrostatic pressure, causing peripheral edema. As before, the CVP and IVC may be congested and plethoric because of the failing right ventricle, and this is really driven by a decrease in right ventricular ejection fraction, right ventricular end diastolic volume, and an increase in right ventricular end diastolic volume and pressure. As we mentioned before, the failure of the left ventricle will lead to a backup of blood into the lungs, an increase in pulmonary vascular pressures. What about what happens with a massive pulmonary embolus? Well, this is an example of acute cor pulmonale. The basic problem is an obstruction to right ventricular outflow, and this leads to a severe decrease in right ventricular ejection fraction, leading to an increase in right ventricular end diastolic volume and pressure. A backup of blood into the venous circulation leads to an increase in central venous pressure and a plethoric IVC. If we look at the outflow side of the right ventricle, because of the obstruction to right ventricular outflow, there is pulmonary oligemia, leading to a decrease in pulmonary arterial wedge pressure and a decrease in the amount of blood going into the left ventricle. This leads to a decrease in left ventricular end diastolic pressure, or a decrease in venous return to the left heart. The heart tries to respond to this by increasing contractility, so there's an increase in left ventricular ejection fraction, but it's fairly ineffective because the ventricle is empty. As a response to this decreased cardiac output, we have an increase in systemic vascular resistance, but because of the poor stroke volume and the lack of blood coming into the left ventricle, we have a drop in mean arterial pressure. This also leads to a general decrease in systemic blood flow. So that was a very brief look at some causes of cardiac failure and the physiology behind them. There's one we didn't talk about, which is cardiogenic shock, but we will mention this in our last lecture, which is all about shock. In summary, with this lecture we talked about various types of heart failure, and in the final lecture we'll look at shock. Thank you.